returns his time. The gentleman from North Carolina, Mr. Butterfield. 5 minutes for questioning.
Thank you very much, Madam Chair, and thank you to the 5 witnesses for your testimony this afternoon. I'm not sure I'll use my full 5 minutes, but I'll get right to it. Starting with you, Dr. Green. Good to see you. Thank you so very much for coming. You mentioned Prime Therapeutics in your testimony, and I very quickly looked it up on the Secretary of State's website. And did I understand you to say that it is a nonprofit organization?
No, not-for-profit organization.
Well, that's the same thing. Nonprofit, not-for-profit.
Blue Cross of North Carolina is a not-for-profit, which means we're also fully taxed.
But Prime Therapeutics, that appears to be a for-profit corporation. Does that sound right or not right?
Not right. It sounds.
Okay.
It should be a not-for-profit organization.
All right. Well, we'll look into it. Is it Prime Therapeutics Specialty Pharmacy, LLC?
That's a subsidiary of Prime Therapeutics. That'd be the pharmacy of Prime Therapeutics.
I see. That's a subsidiary. All right. I'm okay with that. Dr. Ashworth, let me go to you very quickly. I didn't realize that there was a high incidence of unfilled prescriptions. I knew it existed, but I didn't realize it was as high as it is. Do you have any data, any hard data that shows who actually walks away from unfilled prescriptions?
Yeah, I appreciate the question. So we do, and we could follow up with more information to help you understand how those things look. There's another side to that equation, which is 30% of the time, pharmacists get rejected when we try and fill the prescription. So we're doing the prior auths and the step theory discussions that we were talking about before. We partner with our physician partners many times to try and understand formulary changes and different choices that patients have. That's why we're advocating for that data benefit clearinghouse, so that everybody has access to that information at the point when the drug's being dispensed or written by the physician, or when they're at the pharmacy counter. It'd be next level of transparency for the whole system.
So is there a correlation between prior authorizations and treatment abandonment? Is there a correlation between those two?
It's a good question. I haven't looked at specific data. The intuition tells me yes, but we can definitely look to.
Someone mentioned 1 out of 4. Did someone mention that earlier?
I don't have data on that, but I can speak from my experience, which is we see this all the time. So again, because of the lack of transparency, and you heard in the previous panel somebody suggest that at the point of care there are products out there that can help physicians see formularies and see patient copays. Unfortunately, they're small proprietary products that work for one health plan or one PBM, and they're not integrated with our EHRs. And so you'd have to have dozens of different logins, and it's very difficult. So we unfortunately spend an inordinate amount of time on the phone with our colleagues at pharmacies, because their computer system, unlike ours, can run individual drugs, and we just have to try one after the next and waste a ton of their time. So my patients who get stuck in that situation, waiting for a prior auth or waiting to deal with a non-transparent formulary, many times after several days, by the time I've worked it out, have at least given up for a while. Does the prior authorization process need to be reformed? All right.
Yeah, I would comment on
major
that.
reforms or just tweaking around the edges?
No, we would be up for major reform. In fact, thank you, Chairman Eshu, for shopping at Walgreens. But the line you're in is because of this problem right here, is that our pharmacists are spending an inordinate amount of time on the phone trying to obtain that prescription for the person in front of you.
Last but not least, to our friend from AARP, thank you so very much for coming. A great organization that I have supported for many years, not just because of my age, but because of the work, because of the work that you do. AARP has been investigating the impact that rising drug prices has on its members. We all know that. Are high drug prices contributing to racial disparities? Do you have any data on that?
I think to the extent that there are economic disparities within those racial and ethnic disparities, that certainly could play a role, or just in the type of coverage that you have. If you have a plan that doesn't provide adequate coverage for the drugs that you need, that can certainly contribute to not having access to the drugs that you need.
Okay. Thank you. Madam Chair, you're back.
Thank the gentleman.